Hello, this is Dr. Salim. Today we are going to talk about the breast. In this first video, we are going to talk about the breast, the anatomy of the breast, the clinical examination of the breast, and the management of breast pain and nipple discharge. In the next video, we will talk about the common pathologies associated with the breast. And in the last video, that will be the third video, we will talk about the breast cancer. So straight away, let's go to the breast, the anatomy. So the average normal breast extends from the clavicle above to the upper border of the rectus sheath, below and from the midline to the posterior axillary line, that is the anterior border of the latissimus dorsi. It overlies the second to the sixth ribs, the pectoralis major, the serratus anterior, and the upper part of the rectus sheath. It is important to understand the area described is much wider than the visible protuberant breast. The structural tissue is the glandular tissue, the achinous group, which form the lobule surrounded by fat and drained by branching lobular ducts into the lactiferous duct. The intimate relationship of the breast to the skin is explained by the ectodermal origin. It is enveloped between two layers of superficial fascia, the deep portion of which is often confused with but the separate fascia over the pectoralis major. So let's go to the blood supply. The main blood supply to the breast is from the four perforating branches of the internal mammary artery, of which the second intercostal branch is the largest. The rest of the breast is supplied by the axillary artery, namely the pectoralis branch of the thoracoacromial artery, the lateral thoracic artery, and the subscapular artery. The lymphatic drainage of the breast has assumed great importance because it is a channel of which early dissemination of malignant disease. Briefly, the breast drains into the internal mammary chain of the lymph nodes, which lie in the intercostal spaces of the endothoracic fascia, the axillary group of lymph nodes, the opposite breast and axilla, to the liver via the rectus abdominis muscle. Over 90% of the mammary lymph drains into the axillary lymph node. So this part, so that's why when there is an early malignancy, we will learn that when we are doing clinical examination of the breast. So when there is an early malignancy, examination of the breast, there will be axillary lymphadenopathy. That's why when we are staging, when we get to that, when we are in the third video, during breast cancer, we stage the tumors, TNM staging. So lymph node, we examine axillary lymph nodes. If there is an axillary lymphadenopathy or any extra lymph nodes, the breast has advanced to a staging stage, which we will learn in the next video. So let's go to the clinical examination of the breast. So one thing you have to know is that I normally use this mnemonic. Wiper. No matter the examination, it could be endocrine examination, examination of the thyroid gland, examination of a diabetic foot, cardiovascular examination, respiratory examination. Always start with you wash your hands. You introduce yourself to the patient. You tell the patient who you are. You ask for permission. You expose the necessary parts and then reposition the patient. So if it's a cardiovascular examination, for example, you expose the necessary parts. So from the midline up to the level of the chest, you reposition the patient. You crop the patient up to 45 degrees for abdominal examination. The patient has to lie supine. So all these you have to. It varies according to every examination, but the format is the same. So let's straight move on to the clinical examination. So 1. Inspect the breast at rest and let the patient hold her hand over the head. Note the difference in shape, size, or dimpling. Inspect the nipple and note the shape, size, and position to which they point. Check for rashes, sores, or any nipple discharge. Have hairline in supine position on the examining table. Look at the left breast and note the difference from the right. Repeat the same thing on the right. Now, palpate the entire breast for tenderness masses. Squeeze the nipple gently and note any discharge. Repeat the same procedure on the right. Have the woman sit up and raise her arm. Palpate the tail of the axillary region of the breast and look for lymphadenopathy. Repeat the same procedure on the other side of the breast. So after completion, ask the patient to cover herself up and thank her for her time and explain the findings and what would be done to manage her and assure her as well. So breast pain. Let's move on to some symptoms. So breast pain is the commonest breast symptom. About 75% of women will have breast pain in their lifetime, and 50% of referrals to the breast clinic is for breast pain. Indeed, mild premenstrual breast pain can be considered normal. Most causes of breast pain are benign. Unless locally advanced, breast cancer is rarely painful, unless maybe inflammatory breast carcinoma that sometimes there will be pain. Most of the types of breast cancer is merely painless. Since there are many causes of breast pain, a detailed history is required, especially to determine extramammary causes. Patients must be investigated fully by triple assessment and not simply reassured. So, what are the differential diagnosis of breast pain? Differential diagnosis is always very important. So, I always say that when you have a case, the first presenting complaint, you should have your differential diagnosis. You go to history of preventing complaint, you should have a differential diagnosis. You go to on direct questioning, the diagnosis narrows down. Systemic inquiry, it narrows down. Past medical history, social history. So by the time you go through the history, you should have at least two strong differential diagnoses. So if we take example breast pain as a presenting complaint, what are some of the differential diagnoses that you may have? So the mammary causes of breast pain. So one, fibroadenosis or benign mammary dysplasia or fibrocystic disease, breast cyst, acute mastitis, abscesses whether acute or chronic, traumatic factor necrosis, gallotocele, dark ectasia, pregnancy, previous breast surgery. So let's go to extramammary causes. Spondylosis of the spine, pleuritic chest pain, lung infection, angina, esophagitis, herpes zoster, medication such as diuretic and hormonal repressant and antidepressant. So now that you have a if the patient present to the consulting with breast pain, initially how will you manage? Initial management of breast pain. So what are some of the initial management of breast pain? So one, reassurance. Non-pharmacological treatments include, I always say that if you when you say manage, you are managing a patient, it's not all about medication. So you have to start with non-pharmacological treatment, ensuring that, so if the patient is a little bit unsure, reassure them. Non-pharmacological treatment. So in this case, non-pharmacological treatment, the breasts are supported by wearing a well-fitting brassiere. You have to know that most women do not wear a well-fitting brassiere. Most of the time the brassiere is smaller than the breast. So you tell them to wear a well-fitting brassiere. Intake of oral contraceptive, if the person is on oral contraceptive, any hormonal contraceptive or hormone replacement therapy, it should be stopped. And xanthine containing substances such as coffee, tea, chocolate has also been found to be helpful in relieving pain. Topical non-steroidal anti-inflammatory drugs can be used, such as diclofenac. Danazol, which inhibits luteinizing hormone and follicle stimulation hormone, release pain in about 40% of patients. Tamoxifen is an anti-estrogen drug used in the prevention and treatment of cancer. It's useful in alleviating pain. So tamoxifen is a drug that is recommended for women who have a family history of breast cancer. So who have first relative degree family history of breast cancer. So you give tamoxifen, it helps in some way alleviating the breast pain before. So this is the initial management of breast pain. So after all these measures have been taken, investigations can be done, and if a pathology is found, that pathology can be treated. That pathology can be managed. So if, for example, if it's fibrocystic disease that has been found, or if it's a fibroadenoma, it can be excised and biopsy can be done. All right. So let's go to nipple discharge. So discharge from the nipple may be clear, purulent, creamy, green, yellow, brown, or frankly blood stained. It may come from one nipple or both. It may also come from a single or multiple duct in a nipple. In about 30% of patients, a lump is present. Benign dysplasia, duct ataxia, carcinoma, or abscess. The causes of blood-stained persistent serous discharge are intraductal papilloma. That's the most common. Ductal carcinoma, duct ectasia, benign mammary dysplasia. Clear, creamy green, brown, or black discharge is usually associated with benign mammary dysplasia or duct ectasia. A milky discharge is associated with lactation, galactorrhea, or duct ectasia. Galactorrhea may be rarely, but due to prolactinemia of the pituitary. So, whether there is a macroadenoma or microadenoma sitting on the pituitary axis causing hyperprolactinemia, it may sometimes present with nipple discharge, as in galactorrhea. A purulent discharge is caused by breast abscess or duct ectasia. So, how will you manage nipple discharge? Initial management of nipple discharge. The breast is examined for the presence of a lump or generalized lumpiness. The duct or ducts from which the discharge comes from are identified and the areola carefully palpated for the presence of a small lump. The other breast is done similarly. The discharge is examined microscopically for red cells and pus cells. If there is a lump, a core biopsy or a stitching is done. Treatment is directed to the underlying pathology if one is found. So that's it for video 1. So watch out for the next video of some of the breast pathologies. Thank you.